to today's. We thank you all for joining us. Today we are going to be discussing a very important issue. The pandemic has come, and some say it's gone, but obviously the effects are still with us. So today we're going to be talking about the impact of COVID-19 on cancer control, specifically looking at the long-term impacts of COVID-19 on cancer control from the patient perspective, looking at it on the facilities, policy, and research perspectives. We know that COVID-19 came with a lot of issues, really dampening a lot of health systems, exposing the frailties that exist. And for quite a number of countries in the low middle income countries, these health systems were already weak. So we really want to try to look at the long-term impacts on the health system in general, and also explore what measures can be taken to concretize the silver linings that have come out from the pandemic towards strengthening the cancer health systems. We can't deny some of the silver linings that have come out of the pandemic. And indeed, we have seen quite a few publications around it. So today we're going to be having 3 and not 2 speakers. We're going to be having 2 speakers from Kenya talk about their experience with cancer control post-pandemic. And then we're going to have a didactic speaker just giving us a broad overview on what is out there and what has been done. So we have 3 eminent speakers today. We have Dr. Julie Torodo, who is a visiting researcher and board member of the Global Oncology Group at the Institute of Cancer Policy at King's College London. She's also been involved with the UICC, and she's worked with cancer organizations across the globe, really advocating for global action plan on non-communicable diseases, palliative care, and cancer resolutions. And most recently, she's involved with the WHO global strategy to accelerate the elimination of cervical cancer as a public health problem. She will be taking the didactic session, and then we will have Christine Mungo-Sitati, who is going to be serving as, she's going to have 12 functions today, both as a presenter and the host of today's meeting. So Christine, who actually needs no introduction, but I will go ahead anyway. She's the executive director of KENCO, that's the Kenyan Network of Cancer Organizations, which is the umbrella body for cancer civil societies in Kenya. And she is the host of the hub coordinator for the African Cancer Research and Control ECHO. She currently serves in the Kenya National Cancer Task Force that aims to come up with recommendations on improving cancer care and management in Kenya. And last but certainly not the least is Dr. Catherine Yongisa, who is a clinical oncologist at the Kenyatta National Hospital. And it will interest you to know that she was the first female radiation oncologist in Kenya. She's the current head of department of the Kenyatta National Hospital and serves as the regional project coordinator, for the following organizations, which include IAEA, and she's the program lead for the American Cancer Society Patient Navigation. So with that, I will hand it over to them shortly. We are in for a good 1-hour discussion. Christine and Catherine will be sharing some of their experiences in Kenya, like I said before. So, but before I hand it over to them, just a few housekeeping rules. We would really like to see your faces. So if your bandwidth allows you, please do turn on your video. And if you're not speaking, you should mute yourself. There will be a session after the presentations for questions and answers, and we hope we'll really get into it, exploring the various effects of the pandemic at the regional level and country-specific level. But you can still put in your questions in the chat box, and I'll be sure to pick it up during the Q&A and discussion section. So I will hand it over to Christine and Catherine to take us through. Catherine, Christine.
Okay, thank you very much, Amaka, for the introduction. I will first start to kindly
I think your audio, you're not very loud.
Oh, okay. Apologies. I hope I'm now clear.
Somewhat better, but if there's something you can do to make it a bit better.
Apologies. Let me just log in.
I think Mishka has a word for it. She says the internet gremlins, because we could hear Christine a while back very loudly. So I guess, Mishka, your gremlins are at work now.
Not that I like the gremlins, but Dr. Nyongesa has also joined. So if it's feasible for her to lead through the slides, Christine, we could maybe go that route. And welcome, Dr. Nyongesa.
Thank you. Thank you.
Okay. Okay, so please go ahead then.
Yeah, apologies. I was quite clear a few minutes ago, just like Amaka said. Perfect. So I think I'm now audible. Yeah, sorry for that. I don't know what just happened. I was in conversation with Amak and Mishka just a few minutes ago. So today Kenko will be presenting on a very interesting topic, the COVID-19 and access to cancer care in Kenya, specifically the patient perspective. And we want to share a survey that was done by the Kenyan Network of Cancer Organizations, that is KENCO, the Kenyatta National Hospital, and in collaboration with the American Cancer Society. So just like Amaka said, we are two presenters. So next slide, please. Yeah, so in Kenya, cancer is the third leading cause of mortality. And those are our statistics, about 42,000 new cases every year and 27 deaths. And our population is about 53.7 million people. And these data statistics translate to 6 people being diagnosed with cancer every hour and 1 person dying every 15 minutes. So it's quite gloomy in Kenya when it comes to cancer. And so from the onset of the pandemic, we all had global data on the effects of COVID-19 in terms of morbidity and mortality for people living with cancer. So this was quite alarming for us, given our high number of cancer patients. And definitely we were concerned about poor prognosis as a result of COVID-19 and of course the cancer for morbidity. So that was a brief overview of cancer in Kenya. So now for COVID-19 in Kenya, our first case was diagnosed in, was registered or reported on 12 March 2020, quite a few months after a number of countries. And of course, now the very next day, we got strict control measures that were declared by the national government. And we had to follow this just to ensure that COVID-19 does not spread across the country. So this included public transport regulations, social distancing measures. Then 2 weeks down the line, on 27th of March, a night curfew was introduced nationwide. So this was to restrict movement during the night and just to ensure COVID-19 was contained in the country. After another 2 weeks or so in April, all movement to and from the Nairobi metropolitan area was ceased for an initial of 21 days. So now for us in Kenya, the Kenyatta National Hospital, which happens to be the main national referral hospital, is actually in Nairobi metropolitan area. But the COVID-19 statistics that were there at the time showed this area had very high numbers of COVID-19 cases. And so the government wanted to restrict movement just to ensure counties are made safer. Without having, you don't need to come to Nairobi because it might predispose you to COVID-19. So that was initiated. And these regulations, the restrictions, the public transport, the social distancing, the curfew, all these were done on and off. As numbers improved, some measures were lifted. As numbers increased, they were put back. So we saw these for 2 years, 2020 and 2021, on and off. Next slide, please. So now this meant serious disruptions in terms of care. So number one, just like I mentioned, when it means patients are not able to access Nairobi, then it meant serious disruptions. And of course, public transport was a concern. Social distancing was also another concern. So in terms of health services, of course, most patients were told to stay at home to be safe. So this really affected healthcare services for non-communicable diseases, including cancer. Then the containment measures created new logistical challenges in terms of triaging patients who are in need of urgent care. And we already, even before COVID, Kenya already had existing barriers in terms of transportation and access to medicines. The main facility, the main National Referral Hospital has radiotherapy services, has chemo and all the other services. So most patients will come from rural setups to come into Nairobi for this healthcare. Of course, the situation has improved over time as more radiotherapy centers are being launched across the country, but KNH remains the main referral hospital in Nairobi. Then, of course, we had other interruptions, and this made cancer patients more vulnerable. And now for us as KENCO and KNH, and of course with the American Cancer Society, we realized very few studies were there at the time, especially on patient perspectives in terms of COVID-19 induced barriers to care in low and middle income countries. And so this is what triggered us to want to do a survey just to find out what is the real situation in the country and whether what we are hearing from patients is true or not. So we decided to do a cross-sectional survey. Now, KENCO is the national umbrella body for civil society. So we are the patient voice in the country. KNH, as I mentioned, is a national referral hospital, and the American Cancer Society has really invested heavily with a very comprehensive patient navigation program at KNH. So that is why the three partners, we felt it is very important to do this survey. And the aim was to examine the impact of COVID-19, the pandemic on cancer care, specifically among patients in low resource settings in the country. So this survey was conducted in December 2020 or through February.
Christine, your audio seems to be muted.
I actually thought maybe it was me.
Am I audible? I'm told.
Yes, you are now. Mm-hmm.
Yes, so the survey was conducted for 3 months, and recruitment material, we came up with a team that would do the survey. This team was constituted of enumerators from KNH, who are mainly patient navigators. Then we also had a team from KENCO, and together with ACS, we were able to form that team that reviewed the materials, approved what we had, did a pre-test survey on the questionnaire. Then this went through ethical review by an ethical body that is at Kenyatta National Hospital. Then we came up with recruitment material for this survey. And this was circulated online in various social media platforms, especially for Kenko and other networks. Then this really helped to come up with, to engage the public and request them to be part of the survey. And the survey materials was in English and Kiswahili, which are the national languages for the country. So now the data collectors, as I said, were formed from the two organizations. We had to undertake a short training just to ensure that we are ready for this exercise. Then participants were requested to participate in the survey in 3 ways. There were 3 options. One was to either do a self-administered self-questionnaire that was online, sort of like a monkey survey, but with all the questions there. For those who are not able to use the online questionnaire, they were free to call into Kenko, and they were taken through the questionnaire by an enumerator through the phone as answers were being filled. Then we also had patients who were able to come into Kenyatta National Hospital as they underwent their usual sessions at the treatment sessions at the facility. There were enumerators who were assisting them to fill some questionnaires. Of course, this was purely voluntary, and the survey participants, it was made anonymous. So no names were recorded just to ensure confidentiality of the information. Of course, the participants had to be 18 years and above, which is the adult age in the country. Then in terms of analysis, this was done with support from the American Cancer Society, and it was done using SPSS statistics. And I can see ACS is in the session. So if there are any questions on that, definitely we will get answers on that. So I will leave my colleague, Dr. Nyongesa, to take over in terms of the results. Thank you.
Thank you, Christine, for the good presentation. And really still take this opportunity for the ACS for continually supporting Kenyatta Hospital in the patient navigation, which has really made a huge impact in patient care. So from these results, we found that a total of 314 questionnaires were collected, but 284 were found complete. These were from counties all over the country, and 65% of the participants were women. And on the care needs, we noted that 48% of the survey participants were in active cancer treatment, 35% had completed, and a smaller number was in the diagnosis and treatment phase. 84% of the participants actually attended KNH in the course of their treatment, and Kenyatta National Hospital is one of the biggest cancer centers in the country. Patients were noted to travel from long distances, and the mean travel distance was 2.47 hours from the county of residence. So on the economic impact, on these patients with cancer, a very high number, 88% of the survey participants reported a decrease in their household income due to the COVID-19. 79% of the participants were worried that the financial impact of COVID-19 had made it harder for them to afford the cancer care they needed. And this was replicated across the board for those patients who are either in the diagnosis or treatment phase, or they were in the active treatment phase. All of them were worried about the economic impact. There was also an issue about delays in cancer care. Due to the major lockdowns that we had and reduced public transport options, in fact, people were being whipped if you are found outside curfew hours trying to look for any transport. So patients were also caught in that fracas, and this actually led to reduced access to hospital due to the lockdowns and the public transport being curtailed. So participants who lost access to hospital due to COVID-19 travel restrictions were 15 times more likely to experience a cancer delay. And during this period, we had patients called in during using the patient navigation to see how they can be assisted. We also called patients to give them letters. We send letters through email, through WhatsApp, to ensure that patients don't miss their treatment. 50% of the patients reported that their care was affected by the in-country travel lockdowns. And most of 42% actually had delays in diagnosis and in the care of their cancer. So there was also challenges in accessing medication, most important pain relief and other prescription medicines. More than half of the respondents reported not having access to pain relief medicines, and 50% reported not having access to other prescription medicines, such as refills and treatment for other symptoms. Compared to older patients who are over 60 years, younger participants aged between 40 to 59 had lower odds of having access to pain relief medicines. So this study has its own limitations. It is a cross-sectional design, so self-reported information and survey items were not previously validated. Another limitation was the use of multiple modalities likely to introduce biases, such as social desirability of responses, especially for the in-person channel. The travel times were estimated due to lack of exact participant address from the county center to actual homes. Results are thus not generalizable to other populations, but provide a better understanding of the challenges faced by the cancer patients. So in conclusion, cancer patients faced some economic and logistical challenges accessing vital cancer care during the COVID-19 pandemic. The pandemic mitigation policies such as cash assistance, intercounty travel permits, facilitated transport, patient navigators, and much more may be helpful for future issues during a pandemic like this ones. More research is needed to actually examine the exact financial impact of COVID-19 on people living with cancer and healthcare delivery institutions. Thank you.
Thank you for your presentation. Are you done?
So maybe just to mention that this survey was actually publicized. There was a publication for this in the International Journal of Cancer. And those are the details. We'll definitely share the link as Charles shares out the presentation by the team that did this. So thank you very much.
Okay. All right. Thank you so much, Christine and Dr. Christine Yongiso for the presentation. In her concluding statement, said, while the results may not be generalizable, I can confirm that quite a number of them are relatable to what happened here in Nigeria. So we actually did feel, patients really did feel the effects of the COVID-19 and still do anyway. So I'll hand it over to Julie, who will take us further in the didactic. So again, just to remind us as she sets up her slides that we can use the chat box to put your comments in and then set a template for discussions later. Julie?
Thank you to NCI and our Kenyan host for inviting me to give this didactic presentation on this lovely ECHO platform. And thank you, Amaka, for the kind words of introduction. I've been asked to give you an overview of the work of the COVID and Cancer Task Force, of which I'm a founding member. But I think it's great that we started off with a Kenyan case study, and well done to the presenters. I think global attention is shifting to other issues, particularly the Ukraine-Russian war. And there's an assumption, or maybe even a big wish, that we can live with COVID. That does remain to be seen, particularly as we go into a new wave of winters. But that does mean that the discussion about COVID and the impact on cancer control is really a national discussion now. So it's very important that we shift to national perspectives. So as I make my introduction, and I'll be looking at the impact that we do know of the COVID-19 pandemic, I'd like you to consider, are you discussing these issues in your cancer centre or in your hospital? And cancer advocates, are you raising these issues with policymakers? And it's data sets like the study you've just seen that will really get policymakers thinking about what does this mean in our own country. So this is the link to the task force website, and I have presented on the task force to this platform before, so I won't dwell on the objectives, but they are here on the right-hand side. And maybe before I start, I will be sharing these slides as a PDF, so don't worry about rushing down and writing any links or anything. But the task force is now a network of over 46 senior cancer centre directors across 47 countries. We have 59 projects of various sizes ongoing, and we've published to date 87 times across multiple complex ecosystems and therapeutic geographies. I'd like to share this link of eCancer, which is a COVID and cancer intelligence hub that carries all publications in one place, not just from the task force. But I also encourage you to share your research. And eCancer is very open to accepting original research from Africa. And if you'd like any advice or someone to preview your paper before you submit to any journal, the task force is happy to help there. So what I'll do just one point, we have had several sessions accepted at the World Cancer Congress in October, both digital and in person. So you'll be able to tune into those, even if you're not going to Geneva. So what is the impact of COVID-19? Well, we know the pandemic had a major impact on healthcare workers, and there's been some interesting work from individual countries, including Rwanda from the African region. Those have all been published individually, but we are working on a meta-analysis at the moment, and that should be in the public domain by the end of the year. But I think what we really still need is a much longer term understanding of how the pandemic is impacted and will continue to impact on healthcare worker capacity, particularly as issues such as migration or early retirement impact after such a long pandemic. What has been the economic impact been? Well, we've been lucky to have a wide range of economic studies looking at the impact on catastrophic expenditure for patients, as we've heard earlier, the impact on premature mortality, and also the systems, economic impacts for services and systems. But these need to be developed and really need to be applied much more locally, and we haven't seen much in this context for sub-Saharan Africa to date. I'm just going to shift because the gallery is sitting right across my side, so I can't see what I'm meant to be saying. Sorry about that. So the task force has conducted a number of studies on cancer systems, and I think we can say that we've now established strong benchmarks for the impact on delays to diagnosis and treatment due to the lockdown. A major 61 country study looking specifically at cancer surgery delays. But I think what we really still need to look at is the long-term impact again, and really using some of this information to look at detailed analyses in the sub-Saharan African region in particular. and looking at qualitative studies to really address some of the data gaps that we still are aware of. But I've just listed a few of the publications that are really useful if you're interested in this area. And now I can't move the slides along. What's going on? Oh, now Gremlin's got me now. I've moved my gallery somehow. It doesn't work. I'll try it here. There we go. What about cancer research? Well, we definitely have seen an impact on global cancer research funding as well as the level of activity. And we've published on that earlier this year, and just most recently in Lancet Oncology. We're continuing that work with the Reprise study, really looking at a global analysis, and that will be published hopefully by the World Cancer Congress, because we do have a session there, so we'd hope to have good data by then. And that will be complemented by some of the work we've been doing on the status of cancer research across continental Africa in general, and we spoke a little about that at Aortic. That paper is now written and hopefully will also be available by the Congress. And we're also looking at contribution and role of low and middle income countries to global cancer trials. So really trying to push the role of research, especially as a mechanism for coming out and recovering from this COVID pandemic. We've also got a piece of work looking at the impact of COVID-19 on COVID-19 vaccines on cancer. Luckily, we haven't seen such a major impact on COVID and cancer patients as we had feared right at the beginning. But this is really an under-researched area. So we have contributed to the COVAX and Gavi discussions and trying to get cancer as part of their policy discussions. We've developed a joint protocol to look at seroconversion of COVID-19 positivity and the impact that would have over the course of a cancer patient's treatment and outcomes for cancer patients dependent on their seropositivity for COVID. But we have a dearth of work in this area in low and middle income countries. So any data that we do manage to find will unfortunately not really be reflective of the whole globe. You're well aware, I think, of the Global Cancer Global Modelling Consortium. This is using modelling to understand the impact of COVID-19 on cancer control. Of course, again, this is largely using high income setting data at the moment, but we are undergoing a series of major systematic reviews that this data will feed into the WHO work as well as our own. And we hope to start to look at some recovery modelling and scenario planning using the data, the impact data that we have. We've already got some funding to look at that in respect of the HPV vaccine, and we'll be able to hopefully create a platform that will have a country presentation that you can look at different scenario plannings to see, well, if we invested more, how quickly could we come back and recover our coverage, particularly vaccine coverage in this first instance, but we will be looking at other areas of cancer control over time. So we hope that that first level of will be contributing to the Cancer Observatory at IARC by the time of the World Cancer Congress. Oh, here I go again, wrong place. But I think it's safe to say that the serious lessons have not really been learned, and we're still not embedding the resilience, the lessons that we have learned from COVID to build resilience and really look at future preparedness should we have another wave of COVID-19 or any other epidemic. So I think we really need to focus our attention on research outcomes now, really linking to national cancer control planning, think about what's essential in how that might change our cancer plans in the immediate future. And I think what we've also seen, funders are already reluctant to invest in any further research in the COVID area. So it's a real big concern for us that people are moving on and we still have so many unanswered questions. I'm sharing this because it's a report maybe that you haven't seen from the ACT Accelerator Partnership. This is a partnership of international organizations that have come together to share and build on their individual expertise to help support solutions to access both COVID tests and vaccines, but also treatments and health system strengthening for improved response to COVID. They asked collectively, I think this includes organizations like the Global Fund, UNITAID, WHO, UNICEF, World Bank, FIND, Gavi, and CEPI. And their collective ask was for $16.8 billion, big numbers. What they've got so far is $3.3 billion, and this report shows how they've been using it. And the link to the report is there. This is just one graphic to show you how little Africa features in that spend up to now. So I won't go through any of the details. It's really to encourage you to have a look. You might be saying, I can't see the blue. Well, even if you blow it up, I'm terribly sorry to say, there's a tiny little bit of blue if you look very closely. And so my two messages from this area are, one, that money hasn't all been spent. There will be a time lag from monies into this partnership and then being spent. So there's still a real opportunity to engage with ACT Accelerator. And the longer that takes to percolate down to country level, the more opportunity there might be to find synergies between the COVID work and maybe work for cancer. So think about that. And I'm going to come back to that when we talk about the silver linings. Again, she said, there we go. So we've got one publication called The Silver Linings, Understanding Positive Changes to Systems and Cancer Care, which was led by Dorothy Lombe from Zambia before she moved to her new post. So please read that, because it has 10 themes of positive change, and we're now looking at an expanded phase of research to update that. So it's really part of a wider program of lessons learned, and I'm going to dive into those a little bit more. This will be a dedicated session at the World Cancer Congress in October. So in summary, what are the silver linings? Well, the key findings, I think, are this real theme of understanding value in cancer control, and really having forced by the pandemic to think in terms of priority interventions. And this has been very much the case for surgery under lockdown, but the resource constraints have also led us to focus on the absolutely necessary treatments. And I think many of us who've been working in the cancer space have been talking about applying the choose wisely approach to maximize what budgets we do have in low income settings. But the pandemic has really forced us to actually do that instead of just keep talking about it. And so actually, whilst that's a tough lesson, I think it's also a positive that we can really continue to take that work forward. If we look particularly at radiotherapy, the reduction in fractionations per cancer treatment has already been proven. There's good studies to show that we can reduce the number of fractions. This is a benefit from a toxicity profile, but just simply the time that a patient requires in radiotherapy, and of course staff time. We know that we can move in breast cancer from 25 fractions to 15, and in prostate cancer from 38 to 20. Why were we slow to adopt these best practices? COVID has helped us force those changes, and I think it's an opportunity for us to make sure we retain them as we move forward in the sort of post-pandemic phase. An interesting example from Latin America was the need for keeping as many patients out of the cancer center if they didn't need to be there. They actually had to get a waiver to many policy barriers for decentralizing care. And so the challenge now to them is to actually retain that and really help get the legislation catched up today so that those good practices can continue. And of course, meetings like this, international meetings, have been much more inclusive and richer for that inclusion. And I would anticipate that a lot of conferences are still going to continue, at least with a hybrid component, to encourage more international participation. But in that paper led by Dorothy, we also talk about the shadows. So there's some negatives of these positives in that the pandemic has shined a really harsh light on health system weaknesses everywhere, not just in low and middle income countries. we really need to take note and begin mitigating for more resilience, as I've just mentioned. But one of the challenges is also that we're seeing some of the solutions to managing the pandemic are also potentially widening inequities in access and therefore disparities in outcomes. A simple example is using mobile technology to deal with poorer access in lockdown. And if you haven't got access to that technology, you're then doubly burdened. So we really need to learn from that and take that perspective forward as we start to work towards more e-health initiatives, for example. Some of the other learnings for me, well, I think that harsh learning has really got a silver lining, in that we have potentially got a better opportunity to talk about health promotion for cancer control and cancer prevention and control with the public. I think there's more understanding through the experience that we've had to go through with the COVID pandemic, that choices today do impact what happens to you tomorrow. Those people that chose not to get a vaccine or chose not to follow protection advice, some had to learn the hard way, and that's an immediate sort of reaction to a choice that we find very hard to get across, particularly in terms of risk reduction for cancer. And of course, we also saw that many people, particularly those overweight or with respiratory disorders, really suffering in the pandemic. Again, something that they have a choice to influence. Sorry, I'm gonna have to stop that phone. So the second point I wanted to make is that donors and politicians very much caught on the back foot with COVID-19. Although we talked for many a year on pandemic preparedness in Geneva, we didn't really get countries responding well. So what we see is, however, the positive on that is that we have seen, particularly in the global space, a much better understanding of the need for a holistic approach across the care continuum, as we've seen. Sorry about that, someone else's phone. No, where am I? So you have seen with ACT Accelerator, for example, the actions across the care continuum. This is something, you know, as cancer advocates on the call will really appreciate. You've been trying to get this message across for cancer control for many, many years. So I hope that this will, the parallel from COVID to cancer will help get that story across and create more understanding. And then when we come back to the funding issue, I mentioned that time lag, and there might still be opportunities to work through the partnership of ACT Accelerate to find some investments for cancer control. A very simple example is the investment in COVID testing platforms. You know, if we're lucky enough to come out of this pandemic, then those platforms are sitting there underutilized. And certainly there's an opportunity to harness them for the HPV DNA testing that we require for cervical cancer. But there's also opportunities to extend that to other cancer types. And some of these platforms already have modules to include, for example, BRCA testing for breast cancer. So think about how these platforms might be used for cancer control, and work with your policymakers to really try and maximize the opportunity of the investments that they have made and the equipment that they have in place now. So thank you for your kind attention. I apologize for the phone interruption. And I'll just leave you with the questions that I asked you right at the beginning, because it's really up to us to carry this learning that we do have from the COVID-19 pandemic to our policymakers, and really have those conversations in our cancer centres and hospitals, and try and learn from those silver linings. So back to you, Amaka.
Thank you so much, Julie, for that very engaging session. And even though your phone kept beeping, but that wasn't any form of distraction anyway. So, now we're going into the discussion period and Q&A. I don't see any questions on the chat. But I think you have highlighted a lot of issues that need, to be thought through and thought through deeply. One thing that has really come up strong is the fact that there are disruptions in care all around, and I know that we've talked about it before in the echo about the impact on research funding, so I think that having to see that act acceleration there, that might also be a silver lining, even, as we look at it. So are there questions, comments from the people on the call? You want to share some experiences as per, the impact of COVID in your country, where we are, what you're doing? Just to also mention that when you talked about in terms of disruptions with clinical care as a radiation oncologist too, I know that apart from using hypofractionated regimens more, but we are also beginning to see a little reduction in the wait times, because obviously if you have it from 25 to 15, you're able to put more patients on. So in terms of both for the patients, the clinicians, hypofractionation is definitely something that we in my center have continued even post-pandemic as well.
Yeah, that's good to hear.
Yes. As a matter of fact, we actually now have a clinical trial around hypofractionated radiotherapy to show, and I think most other low middle income countries would really see the strong benefits in it, considering we don't have that many facilities as well. Brenda has a question. She says, what lessons can we take from COVID-19 that can amplify the role of community in health promotion and disease prevention?
Well, I think, Brenda, I as I mentioned in my talk, it's always been such a challenge. We know young people smoke, and they think cancer comes when you're old and grey, and they don't think about their behaviours when they're young. We've seen that rapid impact from someone with weaker lung function to really massive impact from a COVID-19 infection. That's visible even in the extent of coughing, let alone any more extreme development of the illness. And so those types of direct action and impact, I think, are really useful to show that what you're doing today does impact on how your illness could develop. I think also we had lots of discussions, certainly where I live in Switzerland, about the ordering of when you could get your vaccine. And so people with considered at risk were those with poor lifestyles, overweight and obese, respiratory disorders due to poor life choices. And so they were made very much aware that they were a vulnerable person. And I don't think a lot of people think about their vulnerability when they're sort of young, mid-age. They don't think about it until much later in life. So it's maybe challenged them to think about their own health. And we have actually just published through the Modelling Consortium a paper on the impact of smoking and how the pandemic has been used by some people to stop smoking, but some have gone over into a more extreme smoking behavior through their isolation. It was more comfort. So again, it shows how different people react, but you could use that data to really explore people's attitudes to why they're actually doing the unhealthy behavior. But I think particularly around physical activity and good body weight, I think people have definitely seen that those who have suffered more with COVID-19 have been those that have that unhealthy lifestyle. So again, it's an opportunity to just open up the conversation, understand people's reasons and why they find it hard to move to a more healthy lifestyle.
Yeah, I just wanted to add that for us, we're seeing that during the COVID pandemic, there was a lot of engagement using social media. A lot of young people began to read some of the things that were really out there in terms of cancer, and then the issue with stigma as well. So I think one of the silver linings, if you would call it, is that there's more awareness there, you know, because a lot of people had gotten into the habit of going on to read things, social media, electronic, you know, all that. And so I think maybe it improved. We don't have the evidence yet, but then we see, particularly in the clinics, people asking more questions, their relatives more open to talk about their disease, because they found during that period that they just weren't the only ones. People were sharing a lot of stuff, you know, so I think that helped too for us.
Yeah, that's a good point, Amaka. I think we were forced to seek our own information, get much more informed, because we were learning along with the scientists, and so I think that's a really good point. That's maybe encourage people to be more proactive and understanding something they don't understand, and certainly cancer still an area of poor understanding.
I just want to know whether our Kenya colleagues also experienced, you know, some change with the level of information dissemination that was going on during the pandemic. Christine or Dr. Yondiso, you want to chime in?
I think what I can say is that that's true, Amaka. We actually had a lot of information that was going on social media platforms. Even for us at Kenco level, we used social media just to pass information on cancer and COVID-19. Then we also had the national government that was using short text messages about COVID-19. And I believe this is also an avenue that can be used even for non-communicable diseases, including cancer, just to educate the public. And at the time, the public was very much alert. But then the time that. Thank you.
Yes.
And probably in addition, there was a lot of panic about COVID and cancer. I mean, when those lockdowns were started, but quickly the government had to review and say, for cancer patients, they need to be given priority because it's a critical illness or a serious illness. So there was no way they should be prevented from accessing treatment. So all that information was like, today they say lockdown, no movement. Then the next day, the president will be saying, no, cancer patients should be allowed, and any other sick patients to be allowed to move from county to county. And information like moved very, very quickly. Thank you.
Okay, thank you. And we see that quite a number of practices have been going on. It's just that, like Julie said, there's quite a depth of information out there. So I think the onus is on us really to really explore the opportunities the Act Acceleration provides and see how we can scale it up. Perhaps use some of these newer models to try to drive home the message of cancer care, especially with citizens, our people coming in at very late and advanced stages. I think even if it's just to start from there and then, you know, really teasing it out and exploring further down, I think that, you know, really beholds on us to really see how we can dive into that. And I think with that, I will hand over to Charles because we are almost at the top of the hour. And just to also say that thank you to all our speakers. Thank you for taking time to share your work and your experiences. Christine, Dr. Catherine, thank you so much. To Julie, thank you. And to all the enormous work that the Modeling Consortium COVID and Cancer is doing. I'm actually involved in writing one of the systematic reviews. So there's a lot of work that is really going on there, and thank you for all that you do. So Charles, over to you. Oh dear, Zippy has been raising her hand. I did not see that. Zippy, do you want to say something for 2 minutes or one?
Okay, thank you. I was just going to, okay, I also agree with what Christine and Dr. Nyongesa have shared about the fact that the information on COVID-19 was really, a lot of false information was being passed around on WhatsApp and other social medias. But just quickly, and thank you for the presenters. It was very interesting. I know I was also part of the silver lining thing, but not very active because we were so busy at that time. But I just wanted to say that immediately we had a lockdown, one of the things we did at Kenya Hospice and Political Session was to do an online survey to ask the hospices and palliative care providers what their challenges were and what the challenges of the patients were, because we realized patients were not being seen, hospices had closed down. So I think we should also look at the challenges that the healthcare workers faced, because as much as the patients faced so many challenges, the healthcare workers also were very lost because this was a new disease. Nobody knew what was going on and everybody was scared. And so they were not also providing services. And once we understood some of the challenges they faced, we started working on how can you address these challenges. One was to give the information on COVID-19. And like Christine said, we particularly actually partnered with the Ministry of Health to develop posters for the public, posters for healthcare workers that went across the country and also on social media, but also looked at how can you support the healthcare workers to continue giving services by addressing the challenges that were particular for them. For example, they did not have PPE. So we got funding from the UK to distribute PPE across the country so that to ensure patients continue seeing, but also to take some of this PPE to the community so that if a healthcare worker is going to visit a patient, they make sure that the patient is also protected. So I think we've learned a lot from COVID, especially about innovation. We had all these mushrooming apps for ordering your medication, and a rider would bring your medicines for you, so you didn't have to go somewhere to buy your medicines. I think we've learned a lot. And for Kenya, I think we were lucky because we had those 3-4 months to prepare as we were reading about what's happening in China, in Spain, and Italy. So thank you very much, everybody. But I think we should also remember that as we're talking about the patients, also let's look at the workforce. Are they prepared morally, financially? Are they knowledgeable and have the needed skills to take care of such situations? So we have to invest in both ways, not just one way. Thank you.
Thank you. Thank you so much, Christine. And we're right at the top of the hour, so I'll just quickly hand it over to Charles to close. Thank you for your comments. Charles?
So thank you very much, Amaka. And indeed, thank you everyone for joining us today. And I would like to pass special thanks to our speakers for today, Dr. Julie, Dr. Catherine, and Christine for the excellent presentations. And we can all agree that the presentations were quite informative. So we are going to share the slides and the recording on Basecamp for our reference. And we can continue with discussions over there. So our next session will be held 2 weeks from now. That will be on June 2nd. And we are going now to be focusing on bridging the cancer diagnostics gap. We are going to be looking at molecular pathology applications for cancer in Africa. So in the coming week, we are going to be sharing the agenda and details on how to join. And we invite you to join us then so that we can continue learning. Otherwise, I wish you a good time. Over to you, Mishka, in case you have anything to add.
Just to say a big thank you to everyone and hope to continue this discussion further. Bye, everybody.
Bye-bye. Have a good evening.
Bye, everybody. Thank you.